Find out more about becoming an ACAMH member and to be part of the advancement of child and adolescent mental health, visit www.acamh.org.
Good evening, everyone. I'm absolutely delighted to greet all our participants today, and thank you for giving information in the chat, and great to learn about all the different contexts you're working in. I love Derry Hannam's comment that she's written a book about being a democratic teacher in a secondary school. That's fantastic. So it's really great to have the information. So thank you all very much indeed. And thank you, ACAMH, for giving some tremendously useful information about the different presentations that are to come. Such a rich diet of research and thinking to educate all of us. And today we're going to speak about young people with urgent mental health needs who often have few alternatives but to come to emergency departments. And therefore, emergency acute hospital admissions can provide and signal important gaps in school and community mental health provision. In this research, Ruth Blackburn and Sorcha are going to describe the way in which administrative data from schools and hospitals can investigate stress and mental health presentations in secondary school aged young children in England. And I very much hope that we will have the opportunity to discuss some of the issues which are relevant for yourselves in the question and answer time. So very much looking forward to that. So before our presenters this evening, Dr. Ruth Blackburn is a senior research fellow at the UCL Great Ormond Street Institute of Health. She works on the eChild project with a particular focus on mental health in children, young people, and their families, building on her postdoc innovation work, particularly those particularly interested in those relating to children and young people within school context, adolescent health, with self-harm, violence, drug, or alcohol abuse. She's generally interested in using data science for public health evaluation and policy intervention with vulnerable populations, such an important theme, homelessness, substance abuse, long-term physical and mental health conditions. So Sorcha is a PhD candidate based at the Institute of Global Health, as well as the Institute of Child Health and Institute of Education. And she previously worked as a mental health clinician and psychoeducational consultant across community agencies, child and adolescent mental health services, and hospitals. She's interested in the identification of mental health difficulties and barriers of access to mental health services, with a particular focus on addressing the structural and procedural barriers to care for racially minoritized community, and wants very much to be thinking about how to support their mental health. So it's really great to have you presenting your research, and we really look forward to having the opportunity as participants to raise issues which are of relevance. So please, participants, put your questions in the Q&A, and we'll hopefully have some breaks if it seems to be there are issues to discuss, and we'll certainly have some time at the end. So thank you all for participating, and thank you for Ruth and Sorcha for your presentations. So really look forward to that. So thank you very much indeed. Please, Ruth, are you starting?
Thank you very much for that introduction, and a very warm welcome to everyone who's joining. It's really exciting to see where you're joining us from and to get an idea of the breadth of the audience here. So I'm just going to share my slides. Hopefully those are becoming visible to you now. Excellent. Okay, I'm Ruth Blackburn, and I'm going to be giving this talk with Sorcha. I think we probably don't need further introductions, but yeah, we look very much forward to talking to you this evening about stress and mental health presentations in secondary school aged young people. If you have questions as we go along, please do just pop these in the chat, and if there's anything urgent, we'll try and deal with it straight away. And if there are less urgent things, we will come to them later on in the talk. Okay, so just briefly, what we're going to cover today is what we mean by stress-related presentations. We're going to talk to you a bit about administrative data, so what these are, what we can learn from them, and what some of the strengths and weaknesses are. We're then going to go through the methods, so what we did and the results, what we found for two different studies. I'm going to focus on one which is thinking about the school as a potential stressor and also aid to health-seeking behaviour. And Sorcha is going to focus on inequalities. We're then going to summarise the key messages from those studies and then think about where do we go from here. So that's really about why these findings are important and what, through linking to the wider scientific literature and the wider evidence base, what practical implications these have. And then I'm going to end just with a little note about some of the kind of research horizons and our ideas for the future. And then hopefully we'll have plenty of time for discussion. So first of all, we thought we'd just start with a very quick poll. So this is using a platform called Menti, and I'm hoping that Sorcha will put into the chat a link to this poll. So you go to menti.com and then you enter code 52748188, or you can scan the QR code if you have a phone that's set up to do that. It's a really quick poll. All it's going to ask you to do is to use a sliding scale to say whether you think each of these different conditions have predominantly a physical or a mental health basis. Don't think about it for too long. The answers aren't actually too important, but it's just to get you thinking about some of the decisions that we had to make when we were designing the research that we're talking to you about today. And we'll come back to those results later. What do we mean by stress-related presentations? Well, this really starts with the idea that mental health difficulties often look different in young people compared to adults. And this can reflect that as they get older, adults can learn the skills to identify and express feelings of sadness and worry. Whereas for young people, these are more often experienced as physical, emotional, and behavioural manifestations of stress and distress. So this can include things like irritability, disruptive behaviours, school refusal, withdrawal, difficulty sleeping, poor concentration, and some unspecific physical complaints. So most often this includes things like stomachache and headache. So in this study, we're thinking about presentations of stress that relate to this kind of spectrum of different manifestations, but we're just focusing on the very severe presentations that end up in hospital. And we'll talk much more about that and that pathway later on in the talk. So we know from lots of other work that's been done in this area that there are really significant variations by age and by sex for young people in terms of what these manifestations can look like and how other people in health and education services might respond to them. So for this reason, a lot of the work that we've done stratifies the analyses by age and by sex. So it's really important to say that often when we're talking about these stress presentations, many of them will spontaneously and quickly resolve when the underlying concern is no longer an issue. Typically, these symptoms will disappear, and this is without the need for additional support. In our talk, what we focus on instead is young people who have prolonged, recurrent, or more severe symptoms. And for some of these young people, this may indicate the need for mental health support. But I stress here that it's important that the potential physical causes of these symptoms should be ruled out first. So for these young people who experience these kind of escalated levels of distress and who then have urgent health needs, they often present in acute care settings. So the reasons for this may not be immediately obvious, but we've got an example which is drawn from a case study just to talk through what this could look like. So in this example, we use a patient's story. So when Donna starts secondary school, she enters as a high achieving A student, but as she progresses through her time at secondary school, she starts to experience persistent abdominal pain. This pain keeps her awake at night and causes sleep problems, and she sees her GP in relation to these issues. Somewhat later in school, so in year 10, she finds it increasingly difficult to attend school, and this is in part due to the abdominal pain and also anxiety. And sometimes it's so bad that she needs to go to A&E because there's nowhere else to go. So she is, through this A&E route, admitted to hospital with some of these symptoms, but the medical tests are all normal, and this was also the case when she saw the GP. So by the age of 17, she no longer attends school, and she still has quite a high level of healthcare contact. So in this case study, the patient and her parents had this very understandable and deeply held belief that the pain had a medical cause. So more holistic biopsychosocial approaches to her management, including the validation of her symptoms, were probably needed for things to improve. So just a note here about some of the terminology that we use. So there's a kind of a long history of dubiously named diagnostic labels relating to symptoms that aren't explained by disease. And I've just shown one of the key results from quite an old and actually a fairly small study, which was undertaken with neurology patients. And this was to find out which diagnostic labels patients found more or less acceptable. So we include it here really just to demonstrate that there are lots of different diagnostic labels that have been used for similar clusters of signs and symptoms, and that any of these terms really has the potential to cause some offence, but that some of these are definitely less suitable than others. So for the work that we're presenting today, we've used this term stress-related presentations, and we accept that this terminology may be far from ideal, but given the focus of our work, which is actually on stress as a potential, on schools as a potential stressor for some children, stress-related presentations seemed a more appropriate term for the research. So why do this research on stress presentations? So I think this audience will need no reminder that mental health in young people is an urgent issue, with really quite high rates of young people with probable mental disorders, but only a minority who actually receive treatment for these needs. So part of the reason why only a minority receive treatment is because opportunities for support may be missed or delayed. And in addition to that, there are also really significant bottlenecks in the system that I'm sure many of you are familiar with in terms of gaining access to CAMHS and then potentially having a lengthy wait to actually access these services. So one of the implications of these bottlenecks in the system and missed or delayed opportunities for early intervention are increased pressure on acute care services. So as we heard about in the case of Donna, she went to A&E and was ultimately admitted to hospital. So this pathway is really untherapeutic for the young person. So all too often, young people have to wait for a very long time in A&E, often several days. And they then are admitted to a paediatric or in a general acute ward, where the care they receive for their mental health needs may be suboptimal compared to what they would get in a more specialist setting, or in community mental health settings earlier. So this is bad for the patient, and it's also inefficient for the health system. So by researching these stress-related presentations, we aim to improve the effectiveness of early intervention for these early manifestations of distress as a means of trying to prevent more severe long-term mental health outcomes for young people. So in terms of mental health in schools and care pathways in relation to schools, we want to be really upfront about the fact that for most young people, schools are a source of support. So whether that's through peer groups, through a really exciting and inspiring learning environment, through the stability of a routine, and various other support networks that you get through the school environment. But for some young people, and for some of the time, for many young people, the school environment can be a source of stress, whether this is through factors such as bullying or academic stresses, particularly in relation to exams. However, schools are theoretically well placed but highly under-resourced to recognise and respond to early signs of mental illness. And importantly, they come into contact with so many children that this is really an amazing opportunity for tackling population mental illness at a very high level. Increasingly, we're seeing that mental health support teams and other kinds of community care initiatives, both delivered through the NHS and through third sector organisations, are working with schools to help relieve the bottleneck in accessing CAMHS. However, there are still significant barriers to these services. So we acknowledge that these barriers to access exist to everyone, but some groups are disproportionately affected by them, and that's very much the focus of Sorcha's talk.
So to give you a sense of this deeper dive into inequalities, we know that discrimination, bias, and stereotyping, as well as a lack of cultural sensitivity or awareness, impacts both the risk of experiencing mental health difficulties, but also barriers to accessing mental health care. So UK research shows that individuals from minoritized ethnic groups who perceive race-based discrimination experience poorer mental health as well as poorer physical health than those who do not. And this is cumulative. So cumulative exposure to racial discrimination has incremental negative long-term effects on mental health. Among adolescents, a lot of US research kind of consistently shows that racial discrimination has been associated with externalizing problems. So behavior problems, risk-taking behaviors, as well as substance use, and internalizing behaviors or internalizing problems like anxiety and depression. And perceptions of discrimination and microaggressions have also been linked with increased reports of somatic symptoms. So kind of across the board, we're seeing that discrimination is linked with stress-related presentations. And note that these don't need to be direct experiences. So exposure to vicarious racial discrimination, so that's witnessing someone else's experiences or even via social media, that also increases depressive symptoms and substance use among racially minoritized young people. Next slide, please. Great, so as we kind of know, discrimination doesn't just impact mental health, but it also impacts the likelihood of accessing appropriate and timely mental health care. So differences exist in referral and treatment pathways for mental health care for young people in the UK. So minoritized young people are more likely to be referred to mental health services via more adverse pathways. So what that means is that they're less likely to be referred to CAMHS from school or GP, and they're more likely to be referred through social care and youth justice than their white British peers. In addition, London-based research indicates that Black and Asian young people are more likely to be referred to inpatient services rather than outpatient mental health supports. And this indicates that in early identification of and responses to distress among racial and ethnic groups, or kind of racially minoritized young people, this impacts the likelihood of them accessing appropriate and timely mental health support. And additional barriers on top of that might impede receipt of treatment and reduce the likelihood of remaining in treatment. So things like insufficient language translation services or a lack of cultural competence, limited treatment options offered, as well as stereotyping and discrimination. This all kind of perpetuates distrust and feelings of hesitation or caution. So given that minoritized young people experience these exposure to discrimination and additional barriers to treatment, that's why we felt it really important to examine whether there are systematic differences in treatment access when these young people are experiencing significant distress.
Okay, thank you. So I'm going to talk a little bit now about administrative data sources, and we work on the basis here that this probably is not going to be a very familiar concept for many people in this audience. So what we mean by administrative records are information that are created by services such as schools and hospitals as part of their day-to-day function. So, for example, these are created by the contacts that you have with these services. So in the case of schools, we have the example of registrations, which are taken twice daily in most schools. And this information is fed back to centralized organizations like the Department for Education, who will clean it, de-identify it, and link it over time, and make it accessible to researchers such as ourselves. So for hospital records, these are badged under hospital episode statistics, and they really reflect codes relating to symptoms, diagnoses, and procedures that were part of a patient's care when they were admitted to hospital, and which are then coded up by specialist clinical coders at the point at which that person is discharged from hospital. And these codes are then used by the hospital in order to reclaim payment in relation to that patient's care. So for hospital data and other NHS data, this flows through to NHS England, which was previously NHS Digital, who again clean it, link it over time, and provide de-identified data to researchers to apply for. So historically, these data sets have not been linked between different data providers. And so this has meant that education and health records, for example, could not be analysed together. So the research team that we are part of has created this database called eChild. So in a nutshell, what it does is it links at individual pupil or patient level the records which are held in the National Pupil Database. So again, this includes things like registration data, which gets converted into absence, key stage examinations, special educational needs, contact with children's social care services, exclusions, and a range of other information which is collected by the school as part of its day-to-day functioning. And this information is then linked to the healthcare records from hospitals for these children. So everything in the eChild, so all the data in the eChild database is de-identified. So that means that it does not include patient names, NHS numbers, addresses, postcodes, or other information that could be used to directly identify an individual. This information is available from birth up to the age of 24, and actually that age range is about to expand up to 30. And it covers around 15 million pupils. So to give you an example, this would include things like the birth records for a child, so whether they're born at term or preterm, their birth weight, all of their hospital contacts, when they start school, And together, this information can be built up into an understanding of a child's pathway through education and health services. So thinking back to Donna's story, which we discussed at earlier in the talk, and thinking about what we could see in each child with this kind of for this kind of person, what we would see is not necessarily that Donna was achieving A grades in all of her homework in year 8, but we would be able to see her key stage examination results before she started secondary school. Unfortunately, there is no primary care data included in eChild, so we would miss the GP visits that she had and the earlier signs of persistent abdominal pain and sleep problems that were recorded before the age of 14. However, we would see her increased level of absence from 14 up to 17, and also the point at which she dropped out of school. In terms of the healthcare contacts, we'd see A&E attendances and the hospital admissions and all of the codes that were recorded for her in relation to these. And it's these hospital admissions and these healthcare codes that are really central to the work that we are presenting today. So one of the great strengths of data like eChild and hospital episode statistics is that we have this whole nation coverage of children and young people in England. So everybody who accesses NHS hospital services and all those who are in state-mained education or who take key stage examinations. The great limitation of it is that really all we're able to look at is hospitalizations to understand mental health, for which a vast majority of it, in fact, never presents to healthcare settings. So, for example, that would include all those who never disclose their mental health needs, those who informally help seek, perhaps through a discussion with a teacher or a peer, and we also don't get the GP presentations either. So these hospital presentations are severe and they're also biased towards particular types of presentations, such as self-poisoning in the instance of self-harm. However, they are really important because what they indicate is areas of extreme unmet needs where young people really have few alternatives other than to go to A&E and ultimately to be admitted. So what we looked at in these studies, so we used the hospital data in eChild or on its own as part of hospital episode statistics to identify children and young people who had an emergency hospital admission where the main reason for that admission was a stress-related code. So we developed lists of these stress-related codes by searching the literature to see what other studies had used, and also by expanding this list using clinical input. We also included emergency admissions where self-harm was recorded, but this didn't have to be the main reason for that admission. So broadly, we identified 5 different clusters of codes. So these are all mutually exclusive, but more than one type of code could be recorded for each hospital presentation. So for so these groups include somatic and pain-related symptoms, so particularly medically unexplained abdominal pain, headache, breathlessness, fainting, or fatigue. Self-harm behaviours, particularly self-poisoning, as these are hospital records. Internalizing, so anxiety, depression, and eating disorders. Internalizing problems, so disruptive behaviour and substance misuse. And thought disorders, including psychosis and schizophrenia. So as you'll probably have thought about when you were doing that, the Menti poll, some of these somatic and pain-related symptoms are really difficult to attribute to either physical or mental health causes without knowing a lot more about the individual case. And so we've tried to make these groupings as kind of specific as possible by applying different medical and surgical exclusions, which, for example, would exclude anyone who had abdominal pain in combination with surgical procedures that would suggest that there is a medical cause for this. But there are obviously real limitations about the extent to which we can do this reliably. And we'd be really keen to validate these codes further through additional linkages in the future. So, Sorcha, do we need to go to the live poll?
So our live results actually mirror exactly what the team had said as well, yeah.
Okay, brilliant. So full disclosure, these aren't really your results, but they look very similar to your results. So rather than disrupting the flow of the presentation further, we're just going to show you that when we got some of our group to have a go at doing this poll, they had very similar thoughts to you, which is that with the exception of something like chickenpox, where there is a very clear sort of biological basis through viral infection, lots of these other types of conditions or signs and symptoms could really be attributable to either physical or mental health causes, but perhaps to different degrees. So anxiety is definitely more commonly at the mental end of the spectrum. But this should give you some insight into some of the dilemmas that we had when we were trying to develop and refine these code lists. It's really difficult to get it right and to get the right balance of sensitivity and specificity. And this is something you should definitely bear in mind when you're critiquing some of the findings that we show to you today. Okay, and over.
So for our inequalities analysis, we examine group differences based on the variable ethnicity. And it's important for us to acknowledge that this is a proxy, so it's a flawed substitute for the lived experience of individuals from minoritized ethnic groups living in a white British majority country. The reason that this matters is being that ethnicity is not a risk factor, but differential treatment based on race or ethnicity is the risk factor. So the variable ethnicity in UK administrative data includes both race-based and ethnicity-based identifiers. So race, this is the socially constructed classification, relies on someone's actual or perceived physical appearance and ancestry, whereas ethnicity is based on characteristics such as language, traditions, values, belief systems, cultural factors, ancestral origin, religion, and geographic territory. So while there is inherent overlap between racial and ethnic categories, since groups of people who share social characteristics are likely to share physical phenotypes as well, one category does not inherently imply the other. So we'll kind of refer to this as racial ethnic groups throughout, just to honor the fact that there's both identifiers. Next slide, please. So in this project, the categories used will reflect the categories used during data collection. So that's what was recorded during the admission. And that's based on the Office for National Statistics Census categories. And so they don't represent our opinion. So on the left-hand side, you'll see all of the codes that are used within the hospital episode statistics. Due to still kind of small numbers in a couple of these groups, it was necessary for us to combine some of them, but we tried to honor the differences between these groups as much as possible. So you'll see that for white other, we combined white Irish and any other white background. For both mixed race ethnicity categories, we had to combine, so we combined white and Black Caribbean with white and Black African. We also combined the white and Asian and any other mixed background. And the other kind of combination that we did was for any other Asian background and Chinese, and that was for Asian other. We also show on the right-hand side the kind of broad groupings that are often used. So at times we might refer to clusters of groups with similar results. However, like I said, we will try to honor kind of the differences between groups as much as possible. I guess one final note is that these categories represent the ethnicity that was ascribed to individuals during admission. So it's not necessarily how individuals themselves would identify. And also we use the most frequent ethnicity on a young person's record. So sometimes actually a young person has more than one ethnicity recorded. And so we went with what's most frequent. Thanks, Ruth.
Okay, so moving on to some of the results, so what we found. So in the study focused on schools, we were really asking this question, do schools influence mental health? And we looked at this in two different ways. So firstly, we looked at whether rates of stress-related hospital admissions in secondary school aged children and young people were higher in term times than holiday times. And then secondly, we thought about who, so this in terms of schools and their characteristics, and pupils and the characteristics within them are at greater risk of stress-related presentations. So some of the headline results from this study are, first of all, that when we looked at all of the emergency hospital admissions for young people aged 11 to 17 years, we found that stress presentations accounted for 31% of them, so almost approaching a third. So there's a really significant healthcare burden in relation to these kinds of presentations. As I stated before, we were expecting to see really big differences both between across different ages and also between girls and boys. And so what we found when we looked across young people aged 11 to 17 was that 8% of all girls and 4% of all boys were admitted with one of these stress presentations between these ages. And so actually, whilst we're just looking at the very severe tip of the iceberg in terms of these presentations, actually they're not that rare. And I'll come on to what that means in terms of how common they are within schools. So what we also found was that for girls and boys of the same age, girls consistently had much higher rates of stress-related presentations than boys. And there was also a greater increase over age for girls than there was for boys. And for girls in particular, there was this very steep peak in terms of aged 14 to 15 presentations where the rates were highest. For both girls and boys, we found that the rates of these presentations were higher in weeks which were during term time than they were for holiday periods. And as you'll see on the next slide, that was evident even for very short holiday periods. Whilst we've tried to explain some of the limitations around the codes that we've used and the definition that we've used in this study, it does seem to be picking up a very clear signal about something which is either related to school as a potential stressor or schools influencing healthcare contact. And from this data alone, we're not able to say which of those that is. But I think given the experience and the breadth of the audience today, that may well be something that you can tell us about. So this is a very busy slide. I'm going to just pull out some of the most important messages from it. So we've got the rates of these stress-related presentations for girls shown on the top row of graphs, and boys are shown on the bottom row. So as you'll have seen from the previous slides, this is just reinforcing the idea that the rates are much higher in girls than they are for boys. And also that with increasing age, so the younger ages are shown in red and then in rainbow order up to purple and brown, these rates increase with increasing age. So the lighter grey periods show the national sort of holiday periods for schools. So again, there's some uncertainty in this because obviously different schools have different holiday and term time periods, but there are commonalities across most schools in England. The darker grey periods, which you can see in the middle panel here, these relate to the lockdown periods during the pandemic. And this was of interest to us for two reasons. Firstly, because it was a period at which many young people were at home and not in the school environment, but also where there was a huge amount of disruption to the healthcare service. So most of this dip is almost completely explained by changes in healthcare behaviour, healthcare seeking behaviour, because many people, young and old, were deeply concerned about going into hospital due to the risk of transmission of COVID. By the end of the academic year of 2019-20, these rates of stress presentations as measured in hospital admissions were back up to similar levels as the prior year. But by the following year, so by 2020-21, for girls but not boys, there was a significantly higher rate of these stress presentations compared to the last full year before the pandemic. So the next part of the talk focuses on a single year. That's the academic year 2018-19. So we focus on this year because it was the last year before the pandemic. And as you can see from this slide, it gets quite difficult to interpret the healthcare data during the pandemic because of all of the disruptions that were evident through healthcare contacts. So in this slide, this is the first time that we're looking at linked health and education data. So this is really exciting for us because what it tells us is about the healthcare outcomes of young people in relation to the schools that they attend. And for me as a researcher, this is a really exciting area because it gives us the bare bones on which we can start to think about pragmatic evaluations and how pragmatic trials could be carried out with interventions delivered through schools and with the outcomes measured in healthcare. In this slide, though, we're not talking about interventions. We are just talking about how stress-related presentations are distributed across schools. So in this slide, we can see that when we look at a single academic year, so 2018-19, for all pupils in years 7 to 11, so that's approximately ages 11 to 16, we have about 2.9 million pupils in England who are included in this study, of whom 1.2% were admitted to hospital with a stress-related presentation just in this academic year. So that relates to about 35,000 pupils, of which the majority of those presentations were somatic or pain-related, with the next highest grouping being self-harm, and then the rest distributed amongst externalizing and internalizing or mental health related or multiple types of stress presentations. So when we consider these pupils in terms of the schools that they attend, we find that 1.3% of pupils are affected. So this is almost identical to the previous slide, but because some pupils attend more than one school in a given year, then the percentage is ever so slightly different. And so in an average size secondary school of about 750 pupils, this means that there are about 11 pupils per school who have one of these stress-related hospital admissions. And overall, 96% of schools, so almost all, included one or more of these pupils. When we consider the history of pupils who are in that school in that academic year, then that percentage of pupils who are affected, so who have a history of being admitted with one of these stress presentations, increases up to 2.8%, and virtually all schools, so 99%, then include one or more of these pupils. So again, thinking about an average size secondary school, that means we've got about 22 pupils who have this history of being admitted with a stress presentation. So we were also interested in the amount of variation that we had between schools. And we did this in statistical models that took into account differences in the pupils who attend a school and also the characteristics of the school itself. And this showed that once we'd taken into account these differences in the pupils and the schools, that there was actually quite a small amount of variation, so about 1.7%, that was explained by school effects. So this is quite similar to what's been seen in trials looking at mental health in young people and across schools, and also in different cohort studies. So this was quite a reassuring finding for us. So from those models, we're also able to identify which school and pupil characteristics are related to these higher rates of stress presentations. Although I would note that Sorcha has already explained that these are in many cases, proxies for the things that we would truly want to measure. They are simply dictated by the availability of information that's collected in the data sets. So in particular, for school characteristics, local authority schools rather than special schools had higher rates of stress-related presentations. And in terms of actionable sort of messages for schools, there were a range of characteristics in terms of the pupil intake and their individual characteristics, which are really important to investigate further here. So these are in terms of pupils who've ever been excluded, those with persistent absence in the prior year, those with SEND provision, and who ever have free school meals before the academic year that we're looking at, are identified as being at higher risk of stress-related presentations. We also note lots of other important factors, so notably having contact with children's social care was an extremely important factor, as was having a chronic health condition and a personal history of a stress presentation. One area that we really were somewhat surprised by the results was across different ethnic groups, where we found that ethnic minorities, or some specific ethnic minorities, had lower risks of these stress-related presentations. And that was something that we really wanted to understand more about, and which Sorcha's work explores in much, much greater detail.
The inequalities analysis aimed to explore whether there were systematic differences based on race and ethnicity in hospital-related stress-related presentations, or hospital admissions for stress-related presentations. And specifically, we looked at the rates of admissions as well as repeat admissions. So the kind of percentage of children that were being readmitted, the duration of admissions, so how long they were being admitted for, as well as the types of stress-related presentations that they were being admitted with. Next slide, please. So first, to kind of give you a sense of the results, the trends in yearly rates of admissions for stress-related presentations varied quite a bit across racial ethnic groups. Across ages, though, mixed white, black race ethnicity and the white British group were among the highest rates of admission. There were some slight differences across ages, though. So between ages 11 to 13, Pakistani young people were among the highest rates of admission, whereas this then slowed for 14 and 15 among Pakistani youth, with higher rates among their mixed other race ethnicity peers instead. Next slide, please. Then at the kind of lower end of things, across all ages, white, other, Black, African, and Indian young people were among the lowest admission rates for stress-related presentations. Next slide, please. To give you a sense of the kind of repeat admissions that we saw, so white, British, mixed white, black, and Pakistani young people, so the kind of red boxes you can see had the highest percentage of readmissions. So they were kind of most likely to be readmitted with a stress-related presentation, whereas this was less for other minoritized groups. So white other as well as black other young people were least likely to be readmitted with a stress-related presentation. Next slide. Young people from Black other, Bangladeshi, Asian other, as well as Black Caribbean groups experienced the highest frequency of admissions that were greater than 3 days. So these were the kind of longest admissions. And these are the kind of darkest shades of purple, just to give you a sense. So the white, British, and Indian people were least likely to experience admissions greater than 3 days. So this is, again, quite a lot, but it's to give you a sense of the overarching trends and the types of stress-related presentations that were recorded on admission. Note that the scales are different, but it's really just to give you an overarching visual for these different presentations. So in the top left, you'll see young people from all Asian groups, as well as the Black, African, and other race ethnicity groupings were admitted with potentially psychosomatic symptoms much more frequently than their white and mixed race ethnicity peers. The opposite trend was found for internalizing problems. So that's kind of the top right. You can see that white and mixed race ethnicity groups were admitted more frequently with internalizing symptoms than their racially minoritized peers. So it was highest for white other as well as mixed other young people, whereas in contrast, Pakistani and Black African young people were least likely to be admitted with internalizing presentations. This was a similar trend for self-harm. So self-harm is in the bottom right-hand corner. So young people from all Asian groups, as well as Black African groups, were least likely to be admitted for self-harm. With nearly double those admissions, white British and mixed white Black race ethnicity young people were most likely to be diagnosed with self-harm concerns during an emergency admission. And finally, you'll see in the bottom left corner, this is to give you a sense of externalizing symptoms. So white British and mixed white Black race ethnicity, as well as the mixed other young people, were admitted most frequently with externalizing symptoms. And all Asian groups, as well as the Black African young people, were admitted least frequently with externalizing symptoms relative to their peers. We then took a closer look at thought problem disorders. So this includes diagnoses related to psychosis, so schizophrenia, bipolar disorder, and this is a much smaller subset of stress-related presentation. So it's a relatively rare diagnosis, and for mixed white, Black, as well as mixed other and Indian groupings, the numbers were too small to share, so they were below 10 recordings. However, for those groups that did have kind of higher rates or high recorded diagnoses, there were some very notable differences across racial ethnic groups. So in particular, young people from Black racial ethnic groups, so Black other, Black Caribbean and Black African, were more likely to be diagnosed with thought problem dysdiagnoses on emergency admission than their white British, as well as the mixed race ethnicity, Indian and Pakistani peers. And the proportion of Black other young people diagnosed with thought problem disorders on admission was over 5 times that of their white British peers. So that was 2.5% for Black other young people, where it was 0.5% for white British young people. Finally, we looked at the number of diagnoses recorded during an admission. So during the same stress-related present admission, young people from white and mixed race ethnicity groups were more likely to be diagnosed with more than one type of stress-related presentation. So for example, that would be, say, a psychosomatic diagnosis as well as an internalizing diagnosis, whereas this was much less for the kind of South Asian and Black African groups, where they were more likely to be diagnosed with just one stress-related presentation on admission. So to give you a kind of summary of that, to summarize the general trends. So for the purposes of this, we've clustered groups together based on extreme trends, but keep in mind there is variation within these clusters. So for white and mixed groups, we saw lower somatic related admissions, higher internalizing, higher externalizing, higher self-harm, and higher levels of multiple diagnoses. Whereas for Asian and Black African groups, we saw higher somatic related admissions, so the opposite trend. We saw lower internalizing, lower externalizing, lower self-harm, and lower multiple diagnoses. For Black Caribbean young people, it was a little bit different. So they had less pronounced in either direction somatic symptoms. It was in line with the kind of combined frequency or the average across groups. They had lower internalizing admissions, so similar to the Asian and Black African groups. They had higher externalizing symptoms, so similar, actually right in line with the white British group. And they had less pronounced, but still kind of on the higher end self-harm, and less pronounced in either direction for multiple diagnoses, so kind of somewhere in the middle. And then finally for the Black other and other young people, they were less pronounced in either direction for somatic, so somewhere in the middle, lower internalizing, similar to the kind of Asian, Black African, and Black Caribbean young people. They were less pronounced in either direction in terms of externalizing, so they were kind of somewhere in the middle, and they were less pronounced, but still kind of on this higher end of self-harm, and finally less pronounced in either direction for multiple diagnoses. So again, they were somewhere in the middle. As I mentioned earlier, the trends in thought problem disorder diagnoses were quite unique, so they cannot be summarized in the same overarching trends.
Okay, so just to give you a quick summary of the main findings. So from the schools work, we asked this question of, do skills influence mental health? And the evidence that we see from term time peaks and stress presentations compared to holiday periods provides some evidence that this is the case, which is probably not a great surprise, but that what we can't say is what the mechanism behind this is. And we suspect, but we can't demonstrate from this data, that it's probably different for different groups of pupils. So for some of them, school will be a stressor, and for others, it will be that school will be a dominant influence in help seeking for them. The headline results in terms of using the linked health and education data is that almost all schools were affected. This is actually a really significant public health problem in terms of the scale. And in an average school in a single academic year, but covering all ages within secondary schools, around 11 would be admitted to hospital with stress-related presentation, and 22 would have a history of these kinds of stress-related admissions. We found that there was limited evidence of school effects on stress presentations once we'd taken into account differences in the schools and the pupils within them. However, these characteristics of schools and the pupils within them suggest that school responses, in particular, whether they're supportive or punitive in relation to pupil absence and exclusion, are likely to influence pupil stress. A note of caution is that what we're examining here are really complex relationships between pupil characteristics, school policies, school attendance, and pupil stress and distress presentations. So there are real limitations to how we can do this with this data, and I think future work really needs to look to mixed methods and longitudinal approaches to do this better, and that's something we're very, very happy to discuss further.
So for our inequalities analysis, our kind of key takeaways are that there's quite significant inequalities in the rates of admission for stress-related presentations or differences across groups, as well as differential experiences of emergency admissions. So there's kind of differences in how long children are staying in, the types of recorded diagnoses, and the number of diagnoses that they're receiving during an emergency admission. These differential pathways and potential bias in triage and assessment and treatment likely contributes to these inequalities. We also need to take into account the context of differences in exposure to stress-inducing sociopolitical risk factors like discrimination. And there's also cautious help-seeking behaviours as a result of previous health and education system failures. So where do we go from here? In this last section, we'll shift our focus to consider how can we intervene? What can we do to help shift some of this? There are many gaps in the evidence, so we do draw from different research, from theoretical and legal frameworks, as well as the values of empathy and compassion to indicate healthcare and education targets, considering macro, meso, and micro level determinants. And we have such a wealth of knowledge here tonight, so please add your recommendations, add what you think we should be doing into the chat, things you know of, so that we can all learn from each other as well. So thinking about the legal context, our work sits within the context of the Education, Children and Families and Equality Acts. So we have this legal obligation to facilitate young people to access the support that they need and interrupt systemic factors that might contribute to mental health difficulties. And schools play a central role in prevention and early intervention, identifying young people experiencing mental health difficulties falls under the Special Education Needs Code of Practice, as well as potentially working together to safeguard children, and also mental health and behaviour in schools as non-statutory guidance. So there's a need for us all to kind of, whether it's researchers, clinicians, policymakers, to advocate for young people and families, and kind of advocate for or support them to access through community services things like affordable housing or accessible healthcare. We also need to address discrimination directly and start to implement anti-racism and anti-oppression frameworks in settings, whether it's in schools, whether it's in healthcare settings. So things like the NHS England Patient and Care Race Equality Framework that was recently launched, we need to kind of start to implement this, not just in mental health settings, but across settings as well. Next slide. Within schools, we want to be thinking about incorporating the principles of co-production. So including pupils and parents in the development of school policies and school-based interventions. We want to be expanding the range of support roles. So peer education interventions have been shown to be a promising strategy for health improvement in schools, particularly in increasing health-related knowledge. Also, thinking about adopting trauma-informed principles. So interventions to equip schools to be trauma-informed. This enables schools to understand and respond more appropriately to trauma-impacted students. And this also has a ripple effect for school climate and teacher burnout, right? We understand each other better, we can respond better to each other. And also then when we're centering trauma-informed principles, we can start to think about creating safer environments. So we start to think about providing alternative spaces for children and young people. We start to think about creating supportive connections between pupils, whether that's through peer support or mentorship programs. And this also allows those working in schools to reframe potentially harmful or blaming language. So if we think about reframing attention seeking as connection seeking, we're recognizing the function of the behavior and the young person's need rather than just dismissing it at a surface level. Next slide, Ruth. So in classrooms, while there's mixed evidence to support mindfulness interventions for internalizing symptoms, depending on how well it's delivered or whether young people do the homework, the mindfulness interventions have been shown to decrease externalizing symptoms. They actually help with executive functioning and they decrease kind of conduct problems in terms of, allowing students to regulate better. And similar to trauma-informed schools, it helps to improve school climate and reduce teacher burnout. If school climate is improved and if teachers have more capacity to respond to pupils, this may have an indirect impact on pupils as well, right? Although we do need more research exploring the impact on more severe presentations who we'd be seeing in hospital settings. Also in terms of learning and assessment, encouraging a growth mindset. So this is a culture where mistakes are viewed as opportunities for learning rather than kind of focusing on the grade or the outcome. This has been linked to lower levels of internalizing symptoms. And similarly, by coaching pupils on executive functioning skills, so helping them with time management, with organization, with setting goals, this helps students balance their academic demands more effectively and helps foster a sense of accomplishment and motivation, which may in turn help reduce academic related stress. Next slide, please. So for working with children and families, when we're working with and trying to build a bridge with children and families, we need to acknowledge and be mindful of structural barriers that they may be facing, whether that's income, housing, or food insecurity, or experiences of discrimination based on class, race, ethnicity, language, religion, gender, sexuality. I could keep going. We really need to embody the values of non-judgment and non-blaming, recognizing that ultimately parents want the best for their children and are doing the best that they can with what they have in terms of knowledge or resources and potentially their own fears and instincts to want to protect their children from harm. So we really need to meet them where they're at with a non-judgmental and non-blaming attitude. Then we can kind of think about empowering parents and people. So by providing psychoeducation for parents and sharing information about resources, this normalizes and broadens understandings about mental health, right? Maybe there's a greater understanding of the different types of presentations or how mental health can manifest. And it also, I guess, fostering connections between families with lived experiences at different stages of their journey. So this kind of peer support networks among families has been found to be particularly useful and acceptable to parents as well. So they engage and then they also learn from it. And so by engaging parents in collective advocacy, by engaging them with co-production, it not only builds buy-in, but it also builds trust. And it opens opportunities for developing a shared understanding and creating space to problem solve together. Next slide.
Yeah, so just to kind of wrap up, really, there is so much future research to be done in this area, but one area which I thought would be of interest to get people's views was the use of linked data, so things like eChild, to support pragmatic evaluations and trials of school-based interventions. So clearly with data like eChild, this is only ever going to be a small part of the picture, but I hope that we've shown you some of the importance of this kind of data for understanding what influence schools and the health system have on these kinds of presentations and the kinds of care that people receive. So certainly my vision for work in this area is ultimately to develop trial systems and evaluations that can capitalize on this routinely generated and collected data to help fill some of the evidence gaps and to monitor the impact of interventions that schools are rolling out. There's lots of issues with that, but it's something that I get very excited about. So thank you all so much for listening, and we're really looking forward to your questions as well. Oh, you're muted, Arnon.
Yes, thank you so much, Ruth and Sorcha. I'd also very much like to welcome Professor Ruth Gilbert to the panel, and tremendous, great. Ruth is Professor of Clinical Epidemiology and has responsibility for the development of the eChild research program, which we've heard part of. So I hope she'll be able to help pick up some of the issues that you've begun to raise in your Q&A. Is there anything you wanted to comment on, Ruth, just before we launch into the sort of issues that people have raised?
No, I mean, this is very much really important work, and it starts to sort of give us tools that we can measure in terms of the stress-related presentations. Not perfect, but it's a start, and it's something we can do at scale. And similarly with the sort of the look at the ethnic and racial differences. So it's fantastic work, but we realise that, as Ruth says, there's lots that we don't know, and people in the chat have been saying, what is it about the school environment? We don't know. And so there's lots more research that needs to be done, but we now have this database that can help us, and we need to continually improve that. But I'll shut up because you've got two experts here that have delved into it in huge detail.
Thank you, Ruth. Absolutely, but it's so good to have you on the panel, because I'm sure there are issues which will have a much broader reach, which your comments and contributions will be very valuable. I think that one of the interesting points that raised, one of our attendees raised the issue of the difference between girls and boys, and the issue of the onset of menarche and different pubertal developments, and whether you feel this could have a role in terms of the differential presentations of boys and girls.
I mean, I think it probably does. It's not something we can look at all with this data, unfortunately. And I didn't venture into trying to outline some of the kind of biological, social, and other determinants that could be driving these age and sex differences that we see. I mean, I think the short answer is it's really complicated. I don't know if there's anything Sorcha or Ruth want to add to that.
No. Okay.
We might know, I mean, we'd be interested in your views, Arnon, and others here might have more of an idea about the gender-based, the sex-based.
Yes, well, I do think that there's a lot of interest, isn't there, very generally about responses of girls and boys to stressful contexts, and also relationships within schools and attitudes about boys, should they show their feelings and so on, so that there's a big hinterland about differences between girls and boys, which may very well come into this. One of the questions which did come up was one of our participants noted that in a group of excluded children were children with autistic syndromes, with autistic children and young people, and I'm not sure whether that actually came through in the research.
Yeah, we didn't. As you can probably imagine, hospital episode statistics is not a fantastic source of trying to identify people with autism spectrum disorder. So there has been some work in other parts of the team looking at the extent to which we can look at autism, but I think it's quite difficult with this kind of data. I mean, it's really where having linked clinical records from mental health services as opposed to acute hospital services would really enrich this. And actually, that is very much in the pipeline. It will add a great deal to this, but with HES on its own, it's not something we even attempted to look at in these studies that we've presented today.
Yes, I mean,
sorry, could
yes.
I add? I mean, we've actually got a program running at the moment called the Hope program that I lead, where we're specifically trying to look at whether there's something about special educational needs provision that makes a difference to outcomes of children. And one of the outcomes we'll be looking at is these stress-related presentations. It's very complex, though, because even something like special educational needs, it's quite a complex intervention. We see a recording in the data, but we don't even know whether they actually get the special educational need provision, whether it's of adequate quality and so on. We just, and of course it will be different in different schools and for different people. So it's certainly something that we're working on, and I get a sense in the chat that some people are sort of postulating, and Ruth has certainly raised the idea that if you have that special educational needs provision might be a way of heading off some of these stresses. And that's what we're trying to look at, but it's hard in this data, which is why Ruth comes back to, we also need trials alongside the power of this data.
Yes, very interesting comment by one of our anonymous attendee, working in A&E, assessing young people with mental health crises. We don't admit unless they require medical intervention, as we don't have mental health facilities in the acute hospital. We liaise with community services only. I think many schools feel that young people will get admitted and therefore send them to A&E and ask for discharge summaries because they're then allowed to reattend school, which is a tremendous issue. As we have young people attending for discharge summaries and safety plans and so on. So it really puts acute hospitals under very significant pressure. And this participant indicates that a team of 2 seeing about 70 young people a month, which is very unsustainable. So certainly the issue of the use of hospitals for this sort of service is certainly very concerning, and that comes through, isn't it? I think, and particularly with the tremendous differences through the different minority ethnic studies that you carried out, Sorcha, with this group of young people. So the difficulty is, what would we like to see from this information, particularly about the way in which hospitals become utilized in this way and have very considerable difficulties coping. There has been some interesting work done on trying to work with paediatricians to develop a trauma-informed approach to their work, and being able to have the basic skills, and some work in the States across a number of pediatric services demonstrated that there could be significant changes, and also in schools that there could be significant understanding of the impact of trauma and stress, symptom formation, and different ways of working. So I guess those are some of the ways forward which we'd like to see. Interesting comments about other ways forward that you can see from this work.
I guess one of the things that I would advocate for is kind of greater understanding or awareness of what services do exist, what alternatives do exist, rather than going to hospital. And there are many community-based crisis services, as well as community-based mental health services, if you don't feel comfortable engaging with the NHS. So, actually, one of the projects that I'm working on at the moment is a service mapping. So we're trying to map community-based services that provide mental health support for children and young people. And within that, we want to map how many of them provide crisis support. And so we're trying to kind of crowdsource this directory so that then schools, clinicians have a kind of a database that they can go to and say, okay, if you can't access CAMHS, there are some community services here instead. And so it's kind of increasing awareness of what crisis services do exist that aren't A&E and that do have actual mental health or trained mental health clinicians there instead.
Yes. Is that would be a helpful approach, wouldn't it? And I guess the need for developments across communities, education, school communities, to understand that children and young people may present in a variety of contexts, and that what communities need to develop are a range of ways of supporting and working with children and young people and families, because the skills can be trained across services, can't they? They're not only dedicated to CAMHS. There are many other services that can make a difference, can't they?
And also kind of thinking about how services can collaborate. So building partnerships between schools and community services, building partnerships within kind of local services. So you're meeting the need of the community that you're serving as well. So kind of building those partnerships and those collaborations, and engaging parents and pupils in that. So that's where we're coming back to co-production. So how can we engage with parents? How can we engage with pupils and respond to what they need and what they're saying they need from us as well?
Right. Thank you for that. Just trying to see other comments. Another attendee was saying some schools are observing stress through externalized behavior, leading to children being suspended, excluded, who are simply not able to manage attendance. A group of children who talked about stress linked to unmet needs, undiagnosed cognition, learning needs, neurodevelopmental presentations, waiting lists are so long. Sadly, many children are being failed. So wider systemic issues which require a multi-agency response from health, social care, and education. And I certainly would agree with that, the need for that. It is interesting, isn't it, that in Wales at the moment, they have launched a trauma-informed model across a number of different areas, both universal and more targeted. And schools have a very important role there. And that sort of development, I think, is very sorely needed, isn't it?
Shall I have a go at this? Yes, it's very difficult, and I mean there's many. It's a complex systems solution that we probably need to be looking at, and I think this work. I mean, all these problems have been going on for a long time and well recognised, but at last we're able to measure things at scale, although imperfectly, and part of the big problem is then measuring what people are actually doing about it, as Sorcha says, and then the first steps are to mapping the services. But that's always hard to measure that. But one of the things we're looking at with our policy research unit is the idea that these delays in proactive interventions are actually quite costly in the long term. So, you know, we're looking at with eChild, actually, with the whole trajectory through childhood of health, education and special educational needs and social care, we can see whether some of the more proactive integrated care systems might have fewer or lower crisis intervention costs downstream, which I think is what you're suggesting, Arnon, than others that are less proactively investing in preventive services. So that's sort of pretty, again, crude early work that we'll be starting next year. But it plays to that idea of it's better to intervene early, and particularly for this group, a relatively small group of children with neurodevelopmental conditions and so on, that will account for a very large proportion of healthcare, or at least hospital costs and social care costs, and a very large proportion of the special educational needs budget.
Yes, thank you.
So it's something we need to look at, but and the solutions might be in the integrated care systems and integrated care partnerships, which go outside health. But of course, all of that is quite underfunded and underdeveloped and obsessed with waiting lists at the moment.
Yes, I think Lavinia Dowling mentions that she works in A&E crisis and community CAMHS. There's a really poor partnership, she comments, between education and CAMHS, with the young person being like a political hot potato. And many young people are turned away from CAMHS with identified neurodevelopmental problems. Schools can't be expected to be mental health clinicians. Education needs to consider demands on staff and pupils. Partnerships need to be at grassroots levels with parents. I think it makes that point extremely well, doesn't it?
Very, very useful point. I mean, I think it's very important to consider children and their carers from a health perspective. It's something that we're trying to look at as well. But yeah, often they're not even asked about in these services. Anyway, thank you.
Okay, well, and I think it's very interesting that it's in our Wales and Scotland, where they are really trying to look at a national level about the need to begin working together across services through and with education and with health, and so that there can be much more. And we've got the tools, haven't we? There are ways of working demonstrated very widely that really make a tremendous difference, I think. And I was thinking that the study which I noted on primary schools, which indicated that a 2-day training in understanding the impact of trauma and responses of children and young people, that the greater understanding that teachers had following a 2-day workshop actually meant there was less burnout. The teachers were less burnout, there was less absenteeism, and there was a much better sort of context and atmosphere within the school itself. So, and this was a controlled trial. So I think it demonstrates that that differences can be made, and there can be a real change within the context, and so on. I wasn't sure, Ruth, in the study you did of COVID and the impact in the schools, whether you did notice what the Myriad team have noticed, that there was an interesting difference between schools which had a greater compassionate index and families who had more positive capacities, and that children and young people in schools more compassionate, if they had families who were less coping, showed much more in the way of problems. Whereas in fact, if you had a school with less compassionate responses and as positive family environment, the children and young people thrived. So there's interesting issues with the community, with families, with schools, and so on, that makes a huge difference on stress-related responses, I suspect.
I think we definitely recognise that both the family and the school environment have a huge impact on health and education outcomes. And yeah, as Ruth mentioned, that's very much the direction that we're wanting to go in, is to understand more about the school contextual factors and environment, which of course would require extra kinds of data being brought in to understand more about what it actually is like to be in that school, as opposed to some of the much cruder administrative markers that we have in this data set. And also to be able to look at the overall health of the family, so the adults and children that make up a household who live together. We're not able to do that at the moment, but it's very much part of the vision for the future.
Yes, absolutely. It's an interesting point raised by one of our participants. Knowing the political focus on discipline in schools and concerns from charities, what do we feel the impact is going to be, especially post the pandemic? In other words, the whole issue of discipline control and that whole area of whether schools suspend, whether schools appreciate, understand, and have alternatives to suspension for disciplinary problems and so on. I'm not sure whether those issues came through in the research, or whether that's perhaps another area.
I mean, it's what we found was that in schools where there were higher rates of exclusion and higher rates of persistent absence, they were also having these higher rates of stress presentation. So we were able to observe the association, but we're not able to test through this study what happens if you try and change those things. But I think given the wider literature in this area, you would expect to see that these more supportive responses, rather than the use of exclusion as a punishment, would be expected to reduce stress. But again, it's not something we can directly measure yet.
But it certainly comes through, as you say, in the research, and the countering harshness and punitive responses makes a tremendous difference in families and communities. So it's interesting that you demonstrated that high levels of exclusion were related to more stress responses, which I think is very striking.
We did do a study that evaluated the Head Start intervention, which happened in 6 very deprived local authorities across England. So places like Blackpool and Cornwall, and I can't remember all 6 of them. And we looked at outcomes just in education. And what we saw really, I mean, these were interventions. Each local authority got something like 10 million to intervene for mental health resilience, I think, in was it 12 to 14-year-olds, that sort of age group. And we saw very limited effect on the education data that we could use. It's set for a reduction in exclusions, but that was pretty temporary. And by 2 years later, it had gone back to being the same as the non-intervened areas. So that's as good as we've got on that. So it does suggest exclusions change with interventions. But I think that, exclusions is a sort of crisis intervention at the end of a complex series of problems that reflect teaching capacity, as well as the experiences of the pupils and their underlying needs being met or not.
Yes, thank you, Ruth. And thank you, Ruth and Sorcha, for your presentation and for participating in this very interesting seminar. And it seems to me that the whole of our approach, really looking at the way we can integrate the care, the education, the support of children and young people in the community, in families, is so important. And although the stress-related responses are a small proportion, that many children are not, they're very much, as you were saying in one of your images, the tip of an iceberg in terms of coping, and that we have a long way to go in terms of really trying to ensure that best practice, which does occur, and the good care and community responsiveness, which does happen and is so helpful, that can be reproduced and available for all the children in our country. So thank you very much indeed for participating, and thank you, Ruth, for taking part in the panel, and thank you all participants for the questions and the issues you raised, and as we indicated, you will have the opportunity to have a set of the slides and also a recording of the session, so you can really think about some of the issues which have been raised. So thank you all very much indeed. Thank you.
Thank you.
Thank you so much.
Find out more about becoming an ACAMH member and to be part of the advancement of child and adolescent mental health. Visit www.acamh.org.